Hi, and welcome back to The Checkup. I'm Becky Rupel. With me today, we have Cassi Fiscus. Cassi is our nurse practitioner in our urology department here at the hospital. Thanks for joining us, Cassi.
Thank you for having me.
All right, so today is the prostate episode. So we're talking about all things prostate. Maybe kind of jump in, tell us what it is, why it's important, and why people should be worried about it.
Okay, so the prostate is a gland that sits below the bladder. It's only found in men, so you and I do not have a prostate. Thank goodness, because it wreaks havoc, right?
One less thing to worry about, right?
Yes, exactly. The prostate itself, the job of it is to make semen, so, and help men, do that.
Enjoy that, right?
Exactly.
Right.
And a lot can go wrong with the prostate. As men get older, it can become enlarged, which causes an array of issues with urinary function and such. They can get prostatitis, which is an inflammation of the prostate. I know it sounds
awful.
It sounds as horrible as it is.
Yes.
It's also a very long treatment. They have to be on antibiotics for a month, and they don't usually love that.
I wouldn't think. No, yeah.
And then, of course, I think the big thing that most people hear about is prostate cancer.
Right.
So, like I said, a lot can go wrong with it.
So typically, would you have symptoms? If you were starting to have issues, would you know? Or how would a guy, I'm not going to know, but how would a guy know that maybe he was having issues?
Yes, of course. So with BPH, or that benign enlargement of the prostate, yes, they will have symptoms. They'll have frequency. They'll have urgency. They'll feel like they're not really emptying their bladder completely.
So they got to go. They got to go now, and then they didn't get done when they're going, right? That feeling?
Yes, and they might feel like, oh, my stream is not as strong as it was when I was 20 years old. And I hear all the time men tell me it's not a fire hose anymore like it used to be. So it gets a lot weaker. And the reason that happens is as the prostate gets bigger, it kind of pinches the urethra, which is that tube that drains urine from the bladder. So I always tell men, think about when you put your thumb over the end of a hose, and it kind of sprays every which way. The flow gets higher pressure, but lower volume of urine comes out.
Sure.
That's essentially your thumb is your prostate in that situation.
Oh, that's a good way to describe it.
Yeah.
So, so this is an age-related thing? What age...
Yeah, so
what are we thinking here?
Yeah, of course. I start seeing prostate issues around 40 and up.
That's young, or younger than I would have thought.
Definitely, yes. Yeah. For a prostate cancer perspective, as far as when do we start screening men for that, it depends what guidelines you look at. I usually practice based off the AUA, which is the American Urologic Association, and they say between ages 50 to 69, all men should be screened annually for prostate cancer. And what is screening?
Yeah, that's what I was going to say. Yeah.
I'm reading your mind.
You are. That's great. Buy some lottery tickets.
Yes. Yeah. So PSA, which is blood work that you get done once a year. And then, of course, the other thing that no man is excited about when I mention it is the digital rectal exam.
I'm sure, yeah.
So that is literally taking my finger up their bottom and feeling the prostate for lumps or bumps or anything that just feels abnormal. I'll also do that exam if they're worried about prostatitis, because that exam can give me a lot of clinical data as far as what they've got going on.
Yeah, I'm sure that's not super popular, though.
It's not fun for them. It's really not fun for me either.
Right.
But, we do what we got to do.
Yeah, but that does kind of bring up a good point. So what you do with urology may be make people a little squeamish, a little uncomfortable. So tell me a little bit about what you do to put people at ease when they come in.
Yes.
Yeah.
I will tell you, and I've gotten a lot of feedback from my patients. My office staff is amazing. My nurses, I literally could not replace them. They are worth their weight in gold. They're just so good about bringing the patient in and breaking the ice. And we talk about very intimate things. I say words that I never thought that I would say on a daily basis. And they are words that are not common in practice when you're just conversating. So my one nurse, Tiffany, she will often ask my patients, are you having any erectile dysfunction or pain when you ejaculate or anything like that? And she'll always follow that up by saying, I've really grown. I wasn't able to ask these questions without laughing before. And that just puts the patient at ease. They're like, okay, she knows that this is awkward. I know that this is awkward, but this is why I'm here. So we're going to be open. So, I just go in and I'm like, listen, I know we've got some sensitive topics that we've got to talk about, but I do this every day. Men get really nervous when I have to do any type of exam, whether we're checking the front plumbing or the back plumbing. They're like, ooh. And I'm like, listen, I see penises all day long. I will not remember what it looks like later, I promise. So yeah, just like trying to make it the least awkward as possible for them and bring them ease is
the humor
really
breaks the ice. Yeah, I'm sure it does.
We have to giggle about it, or it will be painful for everyone.
Do you have a lot of, like, the first appointment, is it women calling in for their husbands or partners or whatever, 90% of the time probably?
Yes. I will usually see a wife for whatever her problem may be, incontinence or whatever, and then she'll be like, I kind of like you. My husband gets up 37 times at night. Can you take care of that? I'm like, yes, girl, bring him on in. And then they'll be there the next week, and he's sitting there. My wife made me come. I'm like, well, I hear you're up 37 times a night. And he's like, well, it doesn't bother me. And she's like, well, it bothers me, so let's get that fixed.
Let's get that marked off and taken care of. Yeah. So, so that kind of brings up a good point. What are some of the symptoms that might indicate, like, you talked about the stream, but is getting up at night part of that too?
Oh, absolutely. Yes. If you're not emptying your bladder completely, the receptors in your bladder are going to always kind of be fired. You're always going to feel that urge to go. And think about it when you're moving around during the day, mowing the grass, cleaning up the house, whatever you're doing, you can ignore that. When you're laying in bed at night and everything is still, you can't ignore it anymore. So it's very disruptive to their sleep.
That makes sense. Mm-hmm. Now talk a little bit about, too, I think I'm remembering this right, prostate health can kind of be indicative of maybe more health issues. Is that right? Or am I thinking of something else?
You're thinking of
erectile dysfunction.
Yes,
that's what I'm thinking of. Yes, because that could be a blood flow issue, right?
Correct.
Right.
Correct.
That'll be a separate podcast.
Perfect.
That'll be it, yeah.
I could talk for hours about erectile dysfunction as well, so have me back.
So
I'd be happy to talk about it.
What about, so what are some of the things that, I bring my husband in or whatever, and it turns out he has a prostate issue. What are some things you recommend? I assume, medication or whatever, but talk a little bit about treatment, lifestyle, that kind of thing.
Sure. Okay. So for everyone, men and women, of course, I recommend a healthy, well-balanced diet, normal weight, drinking your water, which nobody likes to hear. Everyone wants to drink their Pepsi and their sweet tea is huge down here.
Oh, really?
Yes. Everyone's like, I drink a gallon of sweet tea a day. And I'm like, okay,
no wonder
we can't do that and not pee our pants.
Yeah. No wonder.
Yeah. So water, I really try and push that more so than the caffeine and the carbonation and things like that. As far as medication and other treatment, it really depends on what the issue at hand is. So for my BPH patients, the people who have really large prostates, we'll start with a daily medication called Flomax or tamsulosin. And what that does is it just kind of relaxes the prostate and the bladder neck to kind of fall off of that urethra, open up that channel, and allow for a more complete flow. I'll see them back usually 6 weeks or so later, see how they're doing. Sometimes they're like, this life has been life-changing. I love this medication. It's perfect. Keep me on it. Other times they're like, it's a little bit better, but it could be even more so. So then we can increase the tamsulosin, or we can add in another agent called finasteride or Proscar. And that medication is really cool as it shrinks the size of the prostate overall. So if you have a man with a really big prostate, 80, 90 grams, whatever it may be, and a normal prostate is 20 grams. I was going to say, you probably didn't know that.
No, I did not. So
Yeah, so like the size of a walnut.
That's exactly what I was going to ask.
Yes, and so when it's bigger than that, the guidelines say if it's more than 30 grams, finasteride is a great option for them. So it shrinks the overall size of the prostate. What I don't love about finasteride is the length that it takes for people to start seeing results from it.
It's not quick acting.
Exactly. No, you don't shrink an organ overnight, right? So
that makes sense.
I mean, you have to be on it for 3 to 6 months before you see improvement in like your urination and improvement in that size. And I feel like our generation is very like they want it and they want it now. So if they take it for a week and they don't notice any difference, they're like, that's not doing anything for me. I'm done with this.
Yeah.
So that's part of my counseling. I'm like, you've got to stay on it for 6 months, and then we can talk about going off of it if it's not working.
Yeah.
There's also surgical procedures. I don't know if you want me to jump into that quite yet for BPH.
So sometimes I think surgery can make
Scare
people a
people.
little scared. Yeah.
For sure.
Especially in that particular area. That's a sensitive area that they don't necessarily want. Yeah.
Absolutely. I always tell people, I'm like, you get to be asleep for this. And usually they're like, well, God, I hope so.
Yeah. I would think, yeah, that's true.
So there's 2 prostate procedures that we do here at Crawford Memorial, and one of them is called a urolift.
Okay.
So if your prostate is minimally elevated or minimally enlarged, so like 60 grams or less is usually where I go for this. We literally go in through the penis, and we pull apart the prostate and then just staple it back. So I know it sounds horrible, but like
I'm a little squeamish anyway.
They come in and they leave. It's minimal pain. Recovery is great. Controls their urinary symptoms. They can pee so much better. It's a very well tolerated procedure.
I don't want to say quick and easy, but maybe.
I mean, it's better than the alternative, which is the TURP, or the transurethral resection of the prostate, which if the urolift made you squeamish, you're going to hate this one.
Yay.
This one, older urologists call it like the Roto-Rooter procedure. So you literally like go in and scrape away parts of the prostate tissue.
Oh my God.
Yeah. Again, generally very well tolerated procedure. The biggest complaint I have on this one is patients have to have a catheter afterwards for like three days, popular. Just because they've got some bleeding and things like that afterwards. So, But anyway, so that's the treatment for a large prostate.
Yeah, I can see why you might go the pill route. Yeah, for sure.
100%. Right. Prostatitis, like we talked about earlier, that looks like 4 weeks of antibiotics. The prostate is very hard to penetrate. Which makes no sense to you guys,
it's
probably.
Also an interesting word to use. So,
yes. It's hard for the antibiotics to get in there and treat the infection. So the prolonged course is because it's taking so long. To get there. Yeah. And then cancer. You want to talk about cancer?
That's what I was getting ready to ask, yeah.
Cancer is it's a hard one without having like a pathology report in front of you. So we'll just start from the beginning. The patient comes in, whether their PSA is elevated or they have an abnormal digital rectal exam. Options moving forward would be a prostate MRI or a prostate biopsy. Okay. The MRI is obviously the least invasive of the two.
And we can do that here.
And we can do that here now, which
is
fantastic. My patients are loving that.
Oh, good. Yeah.
So that is going to look for any like lesions or things that are like characteristic on films that would be concerning for prostate cancer. If that comes back concerning, then we proceed to the prostate biopsy. If the prostate biopsy, which that's a whole thing in itself, again, patient gets to be asleep for this.
Definite bright side, yeah.
Some patients don't. Other people do the prostate biopsies in their office, and I'm like, absolutely not. That is torture.
That sounds horrible.
Yeah.
Yes.
So I always tell them, I'm like, you get to be asleep for this. We roll you on your side. Then we go up your rectum and get 12 samples of prostate tissue. Okay. Send that off to a lab. You meet with me a week later, and we talk about your pathology report. Prostate cancer, the path report can come back very low risk, low risk, intermediate, high, very high risk. And it depends on how many of the cores were positive, how much disease is actually in the prostate, what his PSA was, what his prostate density is. So there's a lot of things that we're looking at to risk stratify them, if you will. Based on that risk stratification, we can recommend treatment if it's needed. Sometimes we just kind of let men walk around with prostate cancer.
Well, that's what I was going to ask. I've always heard that maybe sometimes you can just have it, which seems so bananas to me because cancer is such a...
it's a scary word.
Yes.
It is. Yeah. It is. So yes, low grade and very low grade risk prostate cancer. So if they have low volume disease, their PSA is not that high. This was almost like an incidental finding because we were doing our screenings like we're supposed to. Sometimes they don't need any treatment. Sometimes we can say, hey, I'm going to put you on something called active surveillance where I'm watching you really, really closely with PSA blood draws every 3 to 6 months, annual rectal exams, maybe an MRI in a year, depending on what your PSA is doing. But by watching that PSA as frequently as we are, we're going to know if that's going to progress because we're going to see a big jump.
Oh, okay.
So I think active surveillance sometimes makes people a little bit anxious as well, just because
just
they're
the
like,
idea that you let it go unchecked.
I know that I have prostate cancer and we're not doing anything about it. Again, cancer is such a taboo word. People get very nervous about it. But sometimes that is doing nothing is the best option. As we progress into higher risk categories, so intermediate and high risk, we have radiation therapy. Okay. Prostatectomy, which is where we actually remove the prostate entirely, and then androgen deprivation therapy, which is a injection that the patient gets once every 6 months. Again, we can do that here, and we do it all the time, and that shot decreases their testosterone levels because prostate cancer eats on testosterone, and that's how it grows and thrives. Yeah, exactly.
I didn't know that.
Learn something new every day.
That's right. Call it a day now.
Yeah. So that is kind of the nitty gritty of prostate cancer.
How common is that? Like, how many? Is it a lot? Do you see it frequently?
Super common. Yeah. 300,000 men were diagnosed with prostate cancer in 2024.
Oh my gosh!
It's very prevalent. Yeah. Okay. But only like 35,000 deaths. So.
Oh wow.
That's not very many.
No, that puts it a little bit more perspective when you think about it that way.
The statistic that I use for the men in my clinic, especially those who are like thinking about active surveillance, is 70% of men over the age of 70 will die with prostate cancer, but not from it.
70%. Wow. That's wild.
And a lot of times they only detected the prostate cancer on like postmortem autopsy.
Oh, really?
Yeah. So that's how that study collected that data.
That's interesting. So. All right, switching gears just a little bit, because you weren't in urology your whole career. So tell me a little bit about what brought you to urology, why you like it.
Okay.
Tell me a little bit about that, because I think sometimes people think, why would she want to? So
I literally just had a patient last week who was like, how does one choose this career for themselves? So, yes, before I did urology, I was a newborn nursery level 2 NICU pediatric nurse practitioner.
Yeah.
Yes, this is a completely different world. And, this job just... I tell people, like, urology chose me. I did not choose urology. But it has really worked out really well for me. As far as, like, a home life balance, I have 2 kids and a husband. And, for my previous job, I was having to drive, like, 45 minutes and crossing time zones. And I was on call all the time. So I just wasn't as present at home. And so when this opportunity arose, I was like, I don't know anything about urology, but I'm willing to learn. And I really have learned a lot. In the beginning, I was a little concerned. I was like, ooh, this is not going to top the babies. Like, I loved working with the newborns. But I have found such, like, gratification in my job. Like, people come back and they're like, you know, you maybe didn't save my life, but you did save my life because I can now go on long car trips and not have to pee my pants. Or I literally had a lady the other day, like, I can't even go grocery shopping. I cannot even go into the grocery store and buy my groceries because my incontinence is so out of control. And we got her controlled, and she's like, not only am I grocery shopping, I am going on business trips, and I'm going to my grandkids' events, and this, that, and the other. And so when my patients are thriving, I'm just like, oh, I did that. I helped them. Yeah. And so it's just very rewarding.
I'm sure it is.
And I love it.
You do seem very passionate about it. I mean, in talking to you and different things, you can tell that you love it.
Yes.
Yeah, that you're passionate about it. So,
absolutely.
Is there anything else that you want people to know, either about you or about urology, or what's one thing you want people to take away after they hear this?
I want people to not be nervous to come in and see us. We are a really non-judgmental bunch. We don't care what is going on with you. We just are passionate about wanting to help you get better, whatever the problem may be. And we're right here in your backyard. So there's no reason to go anywhere else but here, because we offer all of those services and we make it as enjoyable as possible.
And how do people get a hold of you? If they need an appointment, have questions, how do they get a hold of you?
Yeah, so they can call the consulting clinic, 618-546-2591.
Okay.
And just make an appointment. I accept self-referrals, so they don't even have to go through their PCP or anything. If they're more comfortable talking to their PCP about seeing me before they actually do, they can always go through their PCP and actually get a referral to us, and then we reach out to them and call them and schedule an appointment, usually within, I would say, a week or two.
That's fantastic.
So we try and make our turnaround times very slim, because when you have problems, they're big.
You don't want to wait. You want to get that taken care of.
Absolutely.
All right. Well, thanks, Cassie, for joining us on this month's episode of The Checkup. We appreciate it, and we'll have you back for
Awesome.
sure.
I love it. Thanks for having me.
so much.
Bye.
Bye.